good morning, or good afternoon, depending on where you are calling in from today. And welcome to the National Partnership for Dental Therapy's webinar on federal opportunities to support dental therapy. Next slide. So for those of you who may not know about the National Partnership for Dental Therapy, the National Partnership is co-chaired by three organizations: Community Catalyst, who I'm with, the National Indian Health Board, who Brett Weber is here representing today, and the National Coalition of Dentists for Health Equity. And we are an organization that works to elevate the visibility and broad multi-sectoral support for dental therapy as an evidence-based way to improve access to oral health. And if you would like to learn more or to add your name to the National Partnership's list of dental therapy supporters, you can visit dentaltherapy.org. Next slide. I guess I should do a little housekeeping. I get excited and I forget that part always. Just so folks know, today's webinar is being recorded. If you are having any tech issues, my colleague Casey Wilson is here and she's handling logistics, so you can just go ahead and message her. We are going to ask folks to add any questions they may have for the presenters to the Q&A box. So just to make it a little easier on folks, if you can add them to the Q&A box, not the chat. So, and like I said, if you're having any tech problems, please message Casey and she will be able to help. So just a little bit of level setting before we dive into a bunch of really great presentations today. Dental therapists are providers who work under the supervision of a dentist to provide commonly needed services like exams and fillings. They have been working in the US for close to 20 years and are currently authorized to work in at least some settings in 13 states. We have 5 education programs for dental therapists in the US. That number is very quickly growing. And there are national education standards in place for the education of dental therapists. The same entity that accredits dental therapy education programs accredits programs for dentists and dental hygienists. And so that is the Commission on Dental Accreditation for folks, which is actually housed within the American Dental Association. So they apply the same standards they do to ensure that dentists and dental hygienists are being trained to provide high quality care to the education of dental therapists. So you can be assured that all the providers are receiving the same quality of training. Next slide. And just as I mentioned, the dental therapists are working or authorized in 13 states, and that is really quickly expanding. And I think this is why, this is such an interesting topic. Dental therapy is very much something that is here to stay in the US. After 20 years, we know that dental therapy is too successful to not eventually expand everywhere. There are so many states that are looking at dental therapy as a policy solution to improve access to care and to diversify their oral health workforces. So we are talking today about some strategies that the federal government could use to support the expansion of dental therapy. And next slide. All right, and we are joined by some wonderful presenters today. I'm not going to do their full bios just for the sake of time, but if you want to see them back on that registration page where everyone registered, you can see them. But we are joined today by Anita Glicken, who is the immediate past chair of the Advisory Committee on Training in Primary Care Medicine and Dentistry. And she is also the current executive director of the National Interprofessional Initiative on Oral Health. And she is also a professor and associate dean emerita at the University of Colorado Ann Schultz Medical Center. Brett Weber, who is a public health policy and programs manager at the National Indian Health Board, will be speaking as well today. Prior to NIHB, Brett worked on the Hill for John Tester. We are joined today by Libby Mullen, who is president of Mullen Strategies. Libby has been a longtime presence on Capitol Hill and has really been championing oral health issues for a very long time, and we are really glad to have her here today. And finally, I am Laura Brannon. Some of you may remember me as Laura Hale. I've been doing this for a bit. I'm project manager for dental therapy at Community Catalyst. All right, now I'm going to hand it over to Anita, and I know she's going to pull up her own slides, so if everyone can just be patient for 1 second while I do that.
Okay, thank you. How's that? Does that work? Great. As the Executive Director of the National Interprofessional Initiative on Oral Health and the immediate past chair of the ACT PCMD committee, I'm really appreciative of this opportunity to be part of this panel, where I'll be speaking about some of the lessons that I learned about federal opportunities to support dental therapy and other health professions over my 3-year tenure at the committee. I am also, like many of you, probably eager to learn more about other federal opportunities that might help us leverage our support, not just for dental therapy, but really in ways that will help us collectively grow and extend our impact through the oral health workforce. So these are some of the topics I'm going to be addressing today. And importantly, what can Title VII funding do in terms of impacting the growth of a new health profession? So the advisory committee was authorized in 1998. And as you can see, the committee provides advice and recommendations to the HHS Secretary, Becerra, and the Committee on Health, Education, Labor, and Pensions in the Senate, and the Committee on Energy and Commerce in the U.S. House of Representatives. And these are the committees that work with Title VII and really decide the appropriations that would be appropriate for the committee's recommendations that we forward directly to them. So we have a direct line, which is incredibly helpful. The committee advises on policy, on program development, and a general statement of other matters of significance that concern issues of medicine and dentistry authorized under Title VII, Section 747 and 748 of the Public Health Service Act. Now, some of these matters included in that are that the committee develops, publishes, and implements performance measures. And in the spirit of longitudinal evaluation, they publish guidelines for that evaluation, as well as recommendations about who and where that information should be collected and analyzed. The committee also makes recommendations for appropriation levels, importantly as part of Part C in the Title VII Public Health Service Act. These activities take place over the course of a year's time, and most often they're submitted through the preparation and submission of an annual report to both the Secretary and Congress. So as you can tell, the main focus of the committee is on primary care practice as broadly defined. And clearly we don't include all professions. These are the primary care disciplines that we focus on and the program areas on that committee. And as you can see, not all are included here because, for example, nursing, which is a big part of our primary care workforce, has its own council that makes separate recommendations to the Secretary and Congress. There are a total of 6 councils or committees that fall under the Bureau of Health Workforce. And these are the ones that the committee is primarily invested in terms of looking at their work. We do now work across committees more than we ever have before to explore and to inform the work of those committees as they go forward. Now, the structure of this committee is that we're a committee, or I keep saying we because I just rotated off, but we're a committee of 17, most of whom were new this year, but actually they were new 3 years ago when I started the term. So at least 75% of committees are typically health professionals, and they have a broad geographic representation of members. It's a balanced membership, so we have a fair number of rural and urban representatives. We also have adequate representation of women and minorities, and we represent the professions listed on this slide. I want to add to explain that Title VII legislation authorizes the Training in Primary Care Medicine and Dentistry Grants Program. So that provides statutory authority to HRSA to award these contracts and cooperative agreements that are aimed at enhancing the quality of primary care training in the United States. Again, this committee was authorized in the 80s, and it's really wanted to just give you an idea of the various programs that are currently undertaken by the Bureau of Health Workforce allocations to medicine and dentistry. And these allocations, recent allocations, are listed there so that you can see how much money is actually invested in the work that we do. Just for sake of an illustration, the slide lists the academic units for primary care training enhancement, for example, which really is funded to create systems level research on primary care training and to disseminate evidence-based best practice and evaluation tools. Many of these programs focus on work with rural and underserved communities, which is what you would expect, and several contain language that specifically addresses the need for leadership and innovative projects to support health delivery system transformation. I thought I would just give you a quick selection of the past reports from 2013 to 2021, so you can get an idea of what types of issues the committee addresses. But I think also what's important to recognize is that many of these issues are issues that we're still addressing today. If you look across these topics from as long ago as almost 10 years ago, interprofessional education, building training in community settings, addressing the social determinants of health, integrated care. And last year, our report again returned to the issue of service and care to underserved and rural communities. And we did that by talking about integrated training, integrated practice, and interprofessional core primary care service across our primary care centers. And that it was inclusive of oral health and mental and behavioral health. Now, I've talked about the committee submitting reports, and we'll talk about our dental therapy report in just a minute. But I also wanted to point out that the committee has the authority to send letters directly again to HRSA and the ranking members of Congress on those committees. And these letters have different purposes. They're sometimes exercised by committees and other times are not. In our case, our first letter that we drafted was actually mandated by legislation. So the CARES Act called for the Advisory Committee on Training in Primary Care Medicine and Dentistry, along with the Graduate Council on Graduate Medical Education, to inform and to advise the Bureau of Health Workforce on a new strategic plan. And in keeping with that CARES Act, we did so, but we also suggested that it was time to bring our various advisory committees together to brainstorm and talk about these issues and to begin to identify whether there would be ways that we could, in a complementary way, support each other's efforts. And that, to my knowledge, was the first time that that had happened. And you'll see later the importance of an action like that by our committees. The second letter that we sent in was support for Title VII funding to address workforce shortages within Indian health facilities. And while that letter had several components, I want to point out that it was a way of foreshadowing our recommendations for dental therapy, because one of the things in that letter was a suggestion to interpret the term other approved primary care dental trainees that are listed under Title VII, and to explicitly include trainees of dental therapy. And that was sort of our foreshadowing of what might come later in a full report. Like the reports, all letters and committee reports are available online for your public review. So let's talk about this report. And one of the things that makes this report unique is that the report only focused on one profession. And this is the first time that the committee has ever done that. I think the committee felt comfortable with that, in part because we had been together for a long time and had spent quite a bit of time the year before developing a shared culture on oral health, a shared understanding that our purpose as a committee really was to focus on population need as opposed to individual profession needs and wants. So we know how easy it is for all professions to be fiscally hungry right now. And I think it's easy to devolve a conversation into advocating for each profession when you have a mix of professionals on a committee like this. So I was pleased that the committee could really focus on the issues at hand and the needs of oral health in this report. Now, there also was another reason that we explored this issue, and that was that there's a history of Title VII funding supporting new professions. And there was actually an academic medicine special issue in 2008 that addressed the impact of Title VII funds to training programs. And one of the things that was noteworthy was the impact it had on the growth of the physician assistant profession, with funding going to programs with a particular focus on faculty development, as well as fundings on the growth of primary care after an initial outpouring of funding to primary care in 1988. So we thought that that was worth paying attention to and helped us to think about what we wanted to do with dental therapy. So I'm not going to go into the entire context and background. I'm sure most of you have a better command of that than I do. But these are the types, this is the information you're going to find in our background section. So if you're looking for a concise way to really talk about these issues, you may want to look at this report, because we tried to do our best to summarize the background and the context of where we are with dental therapy right now. Our recommendations, which I wanted to take a moment to talk about, were constructed as levers for change. We paid attention to what had been funded previously, but also to where the need was in dental therapy. So I'm going to speak about each of these individually, but basically they cover the categories that you see listed on this slide: legislative, funding, program support, not just for infrastructure, but faculty and students. And really, we felt it strongly that there needed to be an emphasis on accountability and measurable outcomes so that we could inform future growth. So our first recommendation was similar to our letter. We recommended the authorizing legislation to explicitly include dental therapy programs and trainees. In our second recommendation, we suggested an increase in the funded appropriation for Title VII, Section 748. And we suggested an increase of $6 million annually to be utilized specifically for dental therapy programs. And we did that in the spirit of not wanting to have to use funds that had already been allocated for other health professions and take those away for dental therapy. We felt that that would create unnecessary strife and concern, and felt that it was actually more appropriate to begin to lay a line in the sand for an allocation directly to dental therapy programs. For recommendation 3, we suggested that faculty of dental therapy training programs be eligible for the Dental Faculty Loan Repayment Program. We know that all health professions, but particularly dental therapy, is challenged in recruiting health professionals to teach in programs, particularly with the state of the art at the moment and the lack of available graduates of programs who might ultimately end up teaching in these programs someday. But we also, again, suggested a funding increase. In this case, it was $1 million to be set aside for the faculty of dental therapy programs. And these don't have to be dental therapists. They don't have to be teaching solely in a dental therapy program, but spending majority of their time there. In recommendation 4, we recommended that the secretary include dental therapy as an eligible profession for scholarship and loan repayment through the National Health Service Corps. And we did some preliminary work in partnering and talking with that committee, advising them on this recommendation and asking if they thought they would be willing to consider looking at their current portfolio and whether or not this was something they could support. So we were assured that they would explore this issue, that it made sense in the context of what had happened with other similar professions, and will be interested in what they do this year with this recommendation. In recommendation 5, we feel strongly that there needs to be accountability on the part of the Bureau as well as in HRSA, as well as programs that are teaching new dental therapy graduates. So we recommended that HRSA actually implement a longitudinal tracking mechanism for dental therapy trainees, faculty, and graduates, specifically including data on trainee and faculty diversity, retention in the profession, educational debt load, graduate practice location, and the population served. So what can you do? How can we take what's available to us in terms of federal dollars and commitment and policies and consider how we might leverage that through the committee on it and the advisory committees that exist currently in the Bureau of Health Workforce? I would suggest considering committee service. Self-nominations are accepted and the committees post what they're looking for. I would suggest attending meetings. All of the meetings are public and they have a public comment period at the end of each meeting so that you can actually let the committees know what your feelings are and what the issues are that your organization might be dealing with. And finally, all committee work can be reviewed online on their HRSA websites. And so I encourage you to use that resource just so that you have an awareness of what the committees are doing and whether there is any impact or influence your organization might have in wanting to share your experience with the committees. So thank you. I look forward to our discussion.
Thank you so much, Anita. And thank you for your leadership on the committee. I think it's really telling that this report was the first time the committee has ever done a report on a sole profession. And I think that really speaks to sort of the importance of dental therapy and what a critical time this is also for dental therapy. So I think this is really exciting. And I really encourage folks to check out the report, not just for the recommendations, but I also think it contains a really great summary of the evidence on dental therapy that is really approachable and sort of include very much expansive of the research base while still being really accessible. So thank you so much, Anita. And we are going to have time for Q&A at the end. So if folks have questions for Anita, you can please put those questions in the Q&A box and we'll have a great conversation later. Next, I'm going to hand it over to Brett Weber, who is going to talk about the Indian Healthcare Improvement Act and the Community Health Aid Program.
Sure. Thank you, Laura. And I'll just reiterate your comments. I have my copy of the report right here, so definitely encourage everyone to read it. But yeah, I'm Brett Weber, Public Health Policy and Programs Manager with the National Indian Health Board. If you haven't heard of us, we are a nonprofit based in Washington, D.C. We were founded by tribal governments in 1972 to serve as the tribal advocate for healthcare. So this is our 50th anniversary. And we have a board of directors that is includes a tribal leader from each service area to be elected to serve that area's tribes as their voice. And you can see a map of the 12 service areas. The Indian Health Service, which is the federal agency that primarily works with tribes to provide healthcare services, divides the nation into 12 service areas for more regionalized and localized healthcare administration. And you can see a map of those areas there. Go ahead to the next slide. Sure. So there are 3 ways that tribes can employ dental therapists. One is by licensing dental therapists to serve that specific tribal community. A tribe in Washington State, the Swinomish, did this in 2016, and they've had a licensed dental therapist working on their lands. The second way is through state licensure, complying with state requirements for dental therapists. And that map that Laura showed earlier, showing the 13 states that have dental therapy state licensing laws. But there have not been any tribes that have gone this route through state licensure. Instead, the most common way is through CHAP implementation. And CHAP stands for the Community Health Aid Program. I'm going to talk a little bit more about that, but basically, CHAP certifies providers, including dental therapists, to provide services in tribal communities that the Western healthcare model has not reached. There are a few restrictions that I'm going to talk about in the Indian Healthcare Improvement Act, but we're going to get to that in 1 second. So I just want to give you a little bit of history about CHAP. It's unique to Alaska because Alaska, I don't know if any of you have ever been there or if you live there, it can be a tough state to provide healthcare services, especially the Alaska Native communities that have maybe, you know, a large one would have 500 people. So that's not necessarily enough people to support a full-time dentist. So, you know, there are other solutions that need to be found. So CHAP, the basic structure is CHAP empowers community members to go through training to become either a medical, behavioral, or dental health provider. Those are the three prongs there: medical, behavioral, and dental. And they get trained and then they go back to the communities that they live in and serve those communities as a frontline provider. It's been around since the 60s. Don't worry about memorizing all of these dates, but it has been around for decades and it's very successful. I do want to point out two more dates on here in addition to 1960. In 2005, the first dental health aides were certified to practice in Alaska. And you'll hear dental health aid therapist and dental therapist. They're functionally the same thing. There's just a minor difference whether one works for the Indian health system, one doesn't, but they're essentially synonymous. And then the second date I want to point out is in 2016, IHS began seeking tribal consultation on CHAP national expansion. CHAP is a wonderful success in Alaska. So in 2016, IHS began the process of expanding it to tribes outside of Alaska. That process is still ongoing, and there's quite a lot of work to do before CHAP is up and running across the country, but they are making progress. So CHAP expansion, like I said, provides routine, preventative, and emergent care in these small rural communities that the Western healthcare model doesn't necessarily reach. Because the people come from the communities that they're serving, there's cultural competence and that they can understand their patient's history, culture, and language. And I mean that literally, not everyone in rural Alaska speaks English as a first language. There's also continuity of care in communities that face recruitment and retention challenges. Because you come from the community that you serve, you're more likely to stay there as a health provider. And then there are also cost savings for tribes and individuals that currently have to travel either long distances or receive care outside of the Indian health system. So CHAP is a good solution to all of these issues. Next slide, please. So I want to talk a little bit about the Indian Healthcare Improvement Act, which is a wonderful seminal law that gives the Indian Health Service authority to provide additional services beyond basic medical services. It was originally passed, I think, in '76 and had to be reauthorized periodically by Congress, and that was always a battle. And if that reauthorization lapses, suddenly the Indian Health Service can't provide certain medical services to tribal populations. So for decades, that was a battle that tribes had to fight on Capitol Hill. The good news is that they don't have to fight that battle anymore. ICHIA, as it's called, the Indian Healthcare Improvement Act, was permanently reauthorized in 2010 as part of the Affordable Care Act. And that is actually the law that gave IHS the authority to expand CHAP to tribes outside of Alaska. However, next slide, please. There is a restriction that tribes cannot use DHATs or dental therapists under national CHAP unless the state that they're in gives them permission. This is extremely problematic because tribal healthcare is it's a federal and it's between the federal government and the tribes. The states are not typically involved. And that is because in our Constitution, the Congress is given the authority to regulate relationships with the tribal governments. And historically, Congress negotiated treaties with tribes And the general flow of those treaties was that tribes would cede land and receive healthcare and other services in perpetuity. So that's where that comes from. And the states, again, are not typically involved. So this, the states being able to give permission here is a little problematic. Well, no, it's very problematic and a little paternalistic. I know everyone's favorite thing is legal citations. So it's the section 25 of the US Code, which deals with Indian tribes. And I put out the actual language here. You can see this bolded. The section is about nationalizing CHAP. So it says, you know, basically Congress is saying that the Indian Health Service can nationalize CHAP, but you shall exclude dental health aid therapist services from services covered under the program, unless, and this is the second bolded paragraph, unless the state that they're in authorizes DHAT or mid-level dental health provider services. So this is obviously something that is not what tribes want to see. And we are working on getting a federal fix to this. So next slide there. We have a one-pager that maybe Laura would be able to send out to the attendees, basically urging Congress to fix this. And you know, basically just deleting those 2 lines of text would make dental therapy available to tribes across the country. So that's definitely something we want to see. And next slide. We also have one thing I do want to do a quick plug for. National Indian Health Board has for the past couple of years been able to offer student sponsorships for dental therapy students to support their tuition and living expenses. It's up to $10,000 per student, and we're able to offer 6 awards. And those students are those that are enrolled in accredited dental therapy education programs for the 2022 to 2023 school year. So there are 2 programs right now that are accredited: Illislavic College in Alaska and Skagit Valley College in Washington State. Those applications are due at the end of this month on September 30th. And then finally, we do have a dental therapy startup guide. It is specifically written for tribal leaders who are interested in bringing dental therapy to their communities. It is, of course, open to the public and accessible. So, you know, feel free to go to our website and download the startup guide. But it does include concrete actions that tribal leaders can take. And I think that is everything I wanted to say. I know I had to go kind of fast. So if there are any questions that we have, I'm happy to get to that at the question and answer. And if you think of a question at 3 a.m. tonight, that is my email. Feel free to reach out. I won't respond at 3 a.m., but I will definitely be happy to answer any questions you have.
Thanks so much, Brett. And can I get the next slide? Awesome. So I believe I'm actually up next to talk about the alternative dental provider grants. I'm also going to say I'm getting a message my internet connection is unstable, so I'm just going to be an amorphous voice with no face for right now, so you guys can hear me. So, you know, we've heard a couple of different ways that the federal government could support dental therapy so far. You know, Anita talked about the recommendations included in the ACT BCMD report, really making sure that existing federal programs allow dental therapists, so adding dental therapists into existing programs. Brett talked about a specific authorizing law that has one added restriction. And Brett, if I'm remembering correctly, it was a restriction that got added in one line at the very last second. The law basically says all of this stuff is expanded, and then there's one tiny little thing that says, but dental therapy. And, you know, which is obviously a restriction that's keeping tribes in a lot of states from being able to hire dental therapists. And so finally, I am going to talk about an existing grant program, which was created to fund programs for providers like dental therapists, you know, as well as other kinds of innovative oral health providers, whether those are like community dental health coordinators or expanded function hygienists, even expanded function dental assistants. We know that there's a lot of innovation in the oral health space. So back in the Affordable Care Act in 2010, one second. Sorry. So in the Affordable Care Act, Congress created a program specifically to put some funding into programs for these kinds of providers to encourage more kinds of innovation, to test these things out, and also generally to get more providers in the field. So this program would make 15 $4 million grants available. However, none of this money has ever actually gone to education programs. And that's because in subsequent funding bills, a restriction has been added that says, no money may be spent on this specific program. Um, and talking, people ask me why that is the case. Um, currently there is no entity that is publicly opposed to this that I have actually seen in the last couple of years. However, um, several years ago, I know the American Dental Association and some of the other dental associations were publicly celebrating the restriction being added each year. So I'll just leave folks to make their own conclusions from that about why the prohibition continues. Earlier this year, over 90 organizations, including Community Catalyst, the National Indian Health Board, the American Public Health Association, the CareQuest Institute, and the National Association for Community Health Centers all sent a letter to Congress requesting that this ban be lifted. And next slide. And I should say this comes on the heels of last year. The House and the Senate actually passed spending bills that removed the block, which we were all really, really excited about. However, when the bills went into conference committee, which is where the differences between the passed bills get worked out, and usually it's kind of a closed door process, all of a sudden that restriction got added back in. So this year, we're not as far along in the appropriations process. For anyone who knows, the federal fiscal year is supposed to start October 1st, which means that technically we are supposed to have basically our federal spending bills passed before then. I'm sure, as Libby can tell you, I think it has been a long, long time since Congress ever actually passed spending bills on time. Instead, frequently you hear these things like continuing resolutions. We're likely going to have another one this year. And that's really how Congress does it. So they're still working on the FY23 appropriations, even though they're supposed to start next month. But in the bills that came out of the subcommittees, so the Labor HHS appropriation subcommittees in each chamber, they both remove the block, which is really exciting. And the reports for both bills contain language talking about the importance of dental therapy. And I just pulled out a quote from the Senate one, which is, "Ending this prohibition will give states the flexibility to further expand access and equity in dental care, particularly in poor, underserved, and rural communities." So I really wanted to raise up this program because a lot of what we're talking about here today could require longer term fixes. Amending Title VII, as the ACT PCMD report requires, was likely kind of a broader change. Obviously only one line would need to be struck from the Indian Healthcare Improvement Act, but that kind of needs its own vehicle perhaps. This is an opportunity for the federal government to support dental therapy right now through an existing bill by not restricting it, by instead following their original intent. So, I think we are all going to be talking a lot more about this kind of in the coming months. And I'm now going to hand it over to Libby. And Libby is going to talk a little bit about some broader oral health activity. We realize that dental therapy does not exist in a vacuum, and policies that are moving at the federal level that affect oral health broadly obviously affect dental therapists. So as we were talking about federal policy today, we did want to give a little bit of a broader snapshot about sort of the big things happening on Capitol Hill about oral health policy. Libby?
Yeah, good afternoon, everyone. Thanks for joining us. And if you are out west, I guess, good late morning to you. I wanted to just say that Laura should have put me up front because I'm sort of the boo of the yay boo story of oral health here. We're really excited, as Laura indicated, and the others on our panel, that there's been a lot of progress and recognition of dental therapy as a key to advancing the workforce and improving access. And we started the 117th Congress out with a lot of hope and promise. There was a bill introduced early in the administration, Build Back Better, that included specific expansion of oral health coverage in Medicare, as many of you are well aware. And truth is, behind the scenes, very deep talks about expanding coverage for adults in Medicaid. In fact, many of us on the call today were involved in those conversations with committee staff, and we know that Secretary Bracero, the Secretary of HHS, is very interested in expansion of oral health coverage in Medicaid. So that was very promising in 2021. We know that the air out of that balloon went out pretty quickly. And when efforts to revive conversations on a budget reconciliation bill were underway, we did still think that there was some hope of expanding coverage in this area. Unfortunately, the dollars were stretched so thinly, and frankly, when it came to healthcare, we were not the winners in that package that we really, I think, advocates were working towards. But what I will tell you is that we made significant gains educating members of Congress, and dental therapy was a big piece of that equation by opening the door for conversations related to dental therapy and appropriations. We could absolutely explain what the consequences of poor oral health were. And I think this year more than ever, being able to connect the dots for policymakers on the implications beyond just health for Americans that have poor oral health, namely economic, whether it is the ability to hold a job, get hired for a job, keep a job, the social consequences of poor oral health, they seem to resonate more this year than ever. So while it's not obvious to the naked eye that we have a bill that passed on coverage, I think there was a real sea change in recognizing that oral health is not just instrumental to overall health, but is instrumental to the economic strength of our economy and our country. So that effort really did tee up some regulatory momentum that is well underway now on getting coverage for medically necessary dental care in Medicare. Now, again, getting the details right there and ensuring that we understand what medically necessary actually covers is going to be really important. And, for those that have spent, their lives working for the underserved and the uninsured, it can feel maybe a little bit disquieting to see all the momentum around Medicare, but it's important to keep in mind that Medicare is often sets the coverage pathway for not just private insurance, but also Medicaid. So Senator Sanders, who is from the state of Vermont, has been awesome on dental therapy, was really leading the charge on the Medicare amendment to the budget reconciliation bill, which was ultimately rejected, but has been a real champion of that effort. And we'll see what happens in the elections. We still have an uphill slog, but I do think that area of coverage has enjoyed more bipartisan support than some of the other areas in health policy. And just as way of kind of more global context, thinking about so that we don't all feel depressed that somehow there is less interest in oral health and in other things, there was definitely a yay boo story in the Inflation Reduction Act passed Congress in August. Certainly, there's a lot of enthusiasm about prescription drug reform. We were all very relieved to see extending the premium assistance in the ACA. And of course, climate change affects all of us, and including our health. So those were all very positive. But the failure to address the significant Medicaid coverage gaps that are out there, or in fact, make CHIP permanent, which by the way, would have cost the government not a penny, or frankly, invest in home and community-based services, were all areas of, for those of us that day in and day out advocate on behalf of the Americans out there that just are struggling to make ends meet and much less pay for affordable healthcare, was a real disappointment. But I think what we do see is a growing recognition that there's a day of reckoning on these things, particularly with the latter on terms of how we're going to care for Americans as they age out. So another area of growing interest is telehealth, and oral health is not always specifically included in the expansion of telehealth services. So there is a coalition of organizations working to ensure that any permanent expansion of telehealth services and coverage also specifically includes oral health. And then just very quickly, I want to touch upon something that is promising. It's going to be an uphill slog, but Community Catalyst is leading an effort with a number of national partners to seek a full review of at HHS of what is required by law under ACA. The law, the Affordable Care Act specifically directs HHS to look at the benefit parameters on a periodic basis. In other words, what is covered under ACA? And to date, no one has looked at that. So we are working hand in glove with some key partners on HHS doing a review and looking specifically at services like adult dental or other areas. So, you know, that's a behind the scenes effort that, again, not everybody is tuned into, but does offer some promise in the area of coverage. And I'll turn it back over to Laura.
Thank you so much, Libby. And I think as folks have really heard, it feels like there is a lot of interest in oral health and dental therapy, specifically on Capitol Hill right now. And while there is definitely setbacks, which are really frustrating, I can say, like, in my years of working on oral health, it feels like I've never heard more people talking about oral health. And Libby, I don't know if you would agree with this, but it feels like I've never heard sort of a more broad understanding of the fact oral health is health. And that, I think, honestly is a big difference, separating out just teeth as like little luxury bones in your mouth, as opposed to saying, like, oh no, the health of your mouth affects the whole rest of your life.
Yeah, precisely, Laura.
Awesome. So I would like folks to go ahead and keep putting questions in the Q&A box, but I have a couple of questions to start us all off with. One of which is to you, Anita. And I know that you have worked on sort of health professions through a lot of your career, and you have a lot of experience, with other health professions as well. So I wondered if you might be able to talk a little bit about your perspective on dental therapy in the context of someone who has worked, with PA professions, social workers, and whatnot. I think those of us who sort of do this work day in and day out, it frequently feels like we're in our own special little slog. But I know from talking with you and other folks who've worked on these issues for a long time that this is actually kind of part of a much broader sort of issue. And these are sort of not unique fights.
I would have to totally echo what you just said. I mean, the dental therapy fight isn't unique necessarily, but I think the process and the struggles and the challenges that one goes through in trying to create a new health profession is similar. My experience has been similar no matter where we're trying to implement it. So I've had the privilege of working with founders of the PA and nurse practitioner profession early in my career and listen to their stories about how they approach the issue, how to identify the right strategies, how to create the policies. And most of, those two professions, much like dental therapy, grew up organically. In fact, dental therapy is probably way ahead in terms of the accreditations for the curriculum and standards, because we didn't have that for those professions. And so it wasn't unusual for that to have to be state by state at that time. And there were strategies that were used that helped move that forward. I would also say that having worked in other countries to create a profession that's an analog to the PA profession, both South Africa, Australia, the UK, I mean, the challenges are always similar. Everyone is fiscally hungry. Health professions are fiscally hungry. There are always challenges between primary care and specialty care, but also there are challenges with concerns about how much overlap there will be between professions. And most importantly, people that are concerned about quality of care. So we need more evidence, which is one of the reasons the committee felt it was important to continue to evaluate the outcomes of the existing programs and to track going forward. So we had a longitudinal perspective on what those outcomes might be of introducing the new field. But yes, and it takes time and a lot of energy.
Thanks, Anita. It occurs to me that we frequently hear folks saying, this is really similar to the battles that PAs went through, physician assistants went through, that nurse practitioners went through. But shockingly, someone was telling me who'd been one of the first hygienists this was really very similar to the battle that hygienists went through in the United States when they were first created. What is it? I don't know, 50, 60 years ago. I'm losing my dates. But the same sort of statements of concern about quality, about displacement of dentists were really heard. And yet, I don't know how many dentists you're going to find today who don't employ a hygienist. It's just clearly a part of the dental field. And I was talking to a dentist who actually works for the Swinomish Indian tribal community in Washington State, who have employed dental therapists since 2016. And he said, I just could never imagine going back to practicing without a dental therapist now that I've had one for so long. Like I feel like I get to do what I like as a dentist so much better. And I think that's like such a great example of the fact that like this seems like a really massive change for folks, but once they actually see what dental therapists are like and have them on their team, they're like, oh, this just makes sense. I never want to go back to the old world. So
Well, I would just say that I think one of the things that's challenging is that in creating a new health profession like dental therapy, we're changing the culture of healthcare. We're changing the culture and pushing, again, for prevention, value, and population health. And I think those are the things, and coming to a shared understanding of a culture of oral health and what that means in our country is going to be really important as we move forward.
thanks, Anita. I also just got another question for you, which is a little more narrow. Was asking about who is eligible to join the ACT PCMD committee. Now, am I correct? I believe by the authorizing law, they set aside certain seats for different kinds, for representatives of different professions. And there's currently not a seat for anyone who is a dental therapist on it, although there is one for a dental hygienist and a dentist. Is that right?
Yes, we do have dental hygienists and dentists on the committee. In fact, Jeff Hicks, who was chair of the Accreditation Council for Dentistry, was actually the co-leader of the dental therapy report that was written, and for the work group that worked on that report. So we do have that. You're correct. Right now, there is not necessarily a slot allocated to a dental therapist. I would add that I'm a clinical social worker. You didn't see social workers listed on that list of health professions, but they actually added at one point the designation that anyone who is working in the area of oral health integration or interprofessional practice or something like that could be part of the committee. So I think that, again, continues to evolve. I think it would be an appropriate committee when the profession has established itself and the Bureau of Health Workforce feels that's the appropriate time to do that. But it wouldn't hurt to raise that issue.
Thanks, Anita. And I did just get a note in the chat that actually the first dental hygienist started work in the US in 1915, which is longer ago than I thought. And it also shows sometimes how long it takes for something to become ubiquitous. And so, we're about 20 years into dental therapy in the US, and we've got to 13 states. So we're doing pretty good, but there is still a ways to go. So I got a few more questions for folks. Brett, I got a question that you might be able to answer. Folks wanted a little more information about what the education requirement is to be a dental therapist under the CHAP program. And also, if you're going to talk about this, I wonder if you might be able to talk about the dental therapy education program that was co-founded by the Swinomish tribe that will be opening later this month.
Sure, yeah, happy to. So the excuse me. The Alaska Dental Therapy Education Program, which was the first accredited dental therapy program anywhere in the country, and which has been training the DHATs that work under CHAP. And again, DHAT is just another term for dental therapist. The way their education works is it's 3 academic years, but it's 2 calendar years. So basically the students don't get summer break. But the first year is classroom learning. So they're, learning about, like biology and kind of more basic medical information in the classroom. Then the second year is clinical work. So they're actually seeing patients in Bethel, Alaska, which is in an area called the Yukon-Kuskokwim Delta. And it's, an area of, I think it's about the size of Oregon, and there's about 50,000 people living in that whole area. So again, you can imagine how difficult it is to provide consistent oral health services. So they're in the clinic in Bethel under the supervision of they're trainers and dentists, seeing patients and practicing their kind of fine hand skills is what it's called. So they do that for another year, and then they do a 400-hour preceptorship again under the direct supervision of a dentist, and then they're certified. So it's pretty rigorous, and not in that program, but in other programs where dental therapists are learning the same thing, learning about scopes and procedures that overlap with the dentist. They're actually learning with dental students, not in Alaska, but in other dental, the ones in Minnesota that are not yet accredited. They're sharing space with future dentists. So it is pretty rigorous training. And I hope that answers your question about the training and about the second program, the Skagit Valley program that was founded in partnership, like Laura said, with Swinomish Tribe in Washington State. They are opening their doors this fall. So they are starting this month, I believe, educating. I think they're capped at 12. They're up to 12 students a year. And again, they follow a similar schedule, 2 calendar years, 3 academic years. And they'll be serving tribes primarily in Washington State, Oregon, and Idaho, which all have authorized dental therapy, but they're also open to they're also open to serving members of tribes, across the country.
Yeah.
So.
And Brett, I know that the program in Washington, it is at a public college, and as they are accredited nationally, if they have room, I think they're able to also just take students from other states. So if you are a student from Colorado or Michigan, and you're not a tribal member and you don't want to work in a tribal health setting, that is still a program that is eligible for licensure in those states.
Yes, that's a good clarification. Thank you, Laura.
Yeah. And just for folks, again, on the context about dental therapy education standards, so like we talked about, there are national accreditation standards set by the same body that accredits programs for dentists and dental hygienists. The standards call for a minimum of 3 academic years, which you can condense into 2 calendar years if you don't get the summer off. But besides that, they really leave up a lot of flexibility to the education program. So that's why you're going to have some programs that are going to have a prerequisite, like a hygiene degree, and you're going to have other programs that don't. You're going to have programs that award an associate's degree or a bachelor's degree or a master's degree, because programs are going to figure out what makes sense for their communities. And because dental therapy already existed in the U.S. before code adopted those standards, we have 5 education programs in the country right now. 2 of them have received their code accreditation, and then 3 others, which are all in Minnesota, are currently accredited, I believe, by the Minnesota Dental Board and are still working through the national accreditation standards. So hopefully we'll have 5 nationally accredited programs soon, but we do have 5 programs. I think we don't have much time left. So Libby, I've got a quick question for you, which is from somebody who is at a community-based sort of nonprofit, and he asked, what can groups like his do to advocate for policies on Capitol Hill?
Great question, and we need as many voices as possible. I can't encourage you enough to get to know your member at a local level. There is so much time. They spend more time back home, and they certainly will this fall than they do in Washington. And there are a lot of events. By just showing up, making the connection that you care about oral health and getting that face time and potentially seeking a meeting even with that office if you don't want to come to Washington, although many of the meetings are now virtual. So know your member, ask for conversations if you can get them, but certainly show up at those public events.
Thank you, Libby. And I think we are pretty much at time. I did see one question I want to answer quickly, which was somebody asking, what are the next steps for the recommendations from the report? So I know that they have been sent to Congress and to the leadership of HHS. So now it's really going to be up to, advocates to encourage Congress and the administration to implement those recommendations. I know there is already a lot of support, on Capitol Hill and within the administration for a lot of those recommendations. But as you heard from Libby, it is hard to get things done sometimes in a really sort of busy political environment. So I think the answer is how do we make sure that those recommendations actually become law? And I think it's going to be everyone has to sort of get involved. So I do want to thank everyone for their time today. we would love to connect with you more. If your organization has not already, we would love you to add your name to the National Partnership for Dental Therapy supporter list at dentaltherapy.org/join. Connect with us on Facebook and Twitter. We are posting quite regularly. And also, if you would like to continue this conversation and don't have my email address, that's my email address. Please reach out to me. And I know all the other presenters as well, I'm sure would be happy to connect if folks have specific questions for them. This is obviously going to be a big topic continuing on the ways the federal government can support dental therapy and oral health more broadly. I think for a long time it felt like there weren't a lot of opportunities federally, and all of a sudden there are, which is amazing, but it also kind of creates a big to-do list for folks. So thank you so much for joining today. We will be sending out a recap of this along with a recording. So stay tuned. That will be in your inbox soon. And thank you all. And thank you so much to our amazing presenters.
Thanks, Laura.